Good afternoon, viewers, and welcome to our fresh edition of our program, Health and Wellness. As you can see, we are full in the studio. My name is Winifred Ukwebo, and I have my co-presenter, Patience Ihejirika.
Good afternoon, viewers.
Yes, good afternoon. And we have a doctor, a physician in the house, Dr. Ubongg Essien.
Yeah, good afternoon, Nigerians. Good afternoon, FCT. Good afternoon, the world. I guess it goes worldwide, right?
Yeah, it is.
Okay, beautiful.
And our guests would like to know more about you. We're curious to know the doctor we have in the house.
Okay. Once again, good afternoon, viewers. My name is Dr. Essien, just like the lady on the right, Winifred, had introduced me earlier. I'm a senior registrar 1 in neurosurgery department, National Hospital of Abuja. Currently, in school, I also double as the secretary of the publicity committee of the Nigerian Medical Association, the FCT branch. In the past year, I served as the state coordinator of the clinical governance committee, the national body of the Nigerian Medical Association. I was also the former vice president of the Resident Doctors Association, National Hospital branch, amongst other portfolios that we've held. But today is not the day for political jargon. So,
yeah, you're welcome once again. Last week, Nigeria joined the rest of the world to mark World Diabetes Day. That is creating awareness on this disease, diabetes. So we want you to share more light on diabetes, the symptoms, and how it can be managed. Although some prominent Nigerians, like Nigeria's former head of state, Olusegun Obasanjo, has also been showing light on how he has been able to manage his own diabetes over time. Perhaps you can start with diabetes and the symptoms.
okay. In medicine, usually we love to talk about guidelines. So the American Diabetic Association guideline 2009 defined diabetes as a metabolic or clinical condition in which you have persistent hyperglycemia. Persistent hyperglycemia meaning high level of glucose, where the fasting blood sugar is more than 6.9 millimoles per liter. Or if you have a patient who has symptoms of hyperglycemia, which include polyuria, polyphagia, I will explain that, with random blood sugar of more than 10 millimoles per liter, or 2 hours postprandial of more than 10 millimoles per liter. So let me take it again. Clinical condition where you have fasting blood sugar more than 6.9 millimoles per liter, persistent.
But doctor, what do you mean by fasting blood sugar?
So fasting blood sugar is you have an individual whose last meal was 10 p.m. the previous day.
Okay.
And then between 8 and 10 a.m. the following day, you check his blood sugar.
Okay.
So that blood sugar is called fasting blood sugar.
Okay.
So if the value is more than 6.9, and is persistent, then that individual is said to have diabetes mellitus.
Okay.
I need to make that correction, because there's also diabetes insipidus.
Yes, okay.
So
and you're also going to tell us, and our viewers too, the difference between, because you've heard of diabetes type 1, diabetes type 2, and all whatnot. So you're just going to
get there.
give us
different panoramic view. So we have diabetes insipidus, we have diabetes mellitus. But what we are discussing today is diabetes mellitus that has to do with hyperglycemia, high levels of glucose in the blood. So we also have types of diabetes mellitus. It can be a type 1, it can be a type 2. You could have gestational diabetes, as those are related to pregnancy and lactation. Okay, so let's go to the type 1. In the type 1 diabetes, there is relative or absolute deficiency in the hormone called insulin. So the underlying problem is that insulin is relatively low or absent. What are the roles of insulin? When you consume carbohydrate-rich food, They are digested by the various organs in the digestive system, and then they are absorbed into the bloodstream. By the time they get into the bloodstream, the insulin that is secreted by the beta cells of the pancreas is located in the left hypochondrium. It secretes several hormones, but one of those important hormones is insulin. Insulin is secreted in response to high level of glucose within the bloodstream. What the insulin does is that it pushes the glucose from the bloodstream into the cells. So you don't have enough glucose within the bloodstream. So what it does is that it reduces the amount of glucose within the bloodstream. So in type 1 diabetes, the insulin that is supposed to be secreted by the beta cells of the pancreas is deficient. And so as you're consuming rich carbohydrate diet, they are being digested, they remain in the blood. They ought to have been moved into the various cells for metabolism to occur, for metabolism of nerve tissues, for metabolism of the muscles you're able to run, because the muscle cells will not be able to do the actions that they do when there is no glucose. So you consume carbohydrate, glucose gets to the bloodstream, insulin mops up that glucose, pushes them into those various cells, so that those cells will have what is required for them, to function. So that is the type 1. In type 2, for every hormone to work, there's what we call the lock and key effect. So what lock and key effect means is that for any hormone to work, you need a key that can plug into the appropriate lock to open it. So that same thing happens with the hormones. For hormones to work, they require receptors. Those receptors are called insulin receptors. And these receptors are located in almost all the body tissues, especially tissues that require glucose. So insulin comes and then blocks on the receptor, activates it, and allows glucose to go into it. So in the type 2, the receptors that are required for insulin to plug into are deficient or are abnormal. So the receptor that's supposed to be maybe say Y shape becomes maybe Z shape. So when the insulin comes, it can't plug to activate it, and so insulin cannot find its way into the cell. I don't know if you get my
Yes, I do.
So you now have glucose.
In other words, type A, doctor, if I'm to understand what you just explained, type A, you have a deficient
fantastic,
insulin,
yes.
Whereas in type B,
insulin is appropriate, present, but the receptors that are required for the insulin to work are faulty. Yes. Fantastic. Okay. You do very well in medical school. So we now have the other one we call the gestational diabetes. This only happens when a woman is pregnant. And commonly people have put them under the type 2 because as you gain weight in pregnancy, those receptors also become deformed. So insulin comes, cannot plug into the receptors, and so glucose remains persistently in the blood, and then it causes all the myriads of symptoms and signs, which we will discuss later. Because the glucose remains in the blood, it's supposed to be in the cells, but they remain in blood, so they now cause myriads of, you go to urinate, you find glucose in urine, you understand, and all that, and all the things we'll discuss much later. So that is basically in terms of classification, type 1, type 2, and then gestational. Some people have also talked about impaired glucose tolerance, but that is not classical diabetes because that can resolve on its own. So classically, you have the type 1, the type 2, and then gestational related diabetes mellitus.
No, the experts have said that diabetes causes a lot of havoc in the body. We are asking you, how can you manage diabetes?
Well, before I go to the management, I think I want to discuss the various havocs that it causes. How long do we have to stay?
You can go ahead.
Okay, so let me start with the havoc that it causes. Remember, as I said, it is due to high levels of glucose within the bloodstream. Yes. There is no organ that is not perfused with blood.
Now, doctor, sorry, before you even discuss the havoc, you want to find out which one is better managed, type 1 or type 2. The one you have insulin, or the one you don't have insulin.
Both of them are better managed. The beautiful thing is that medical knowledge keeps evolving. We get better every day. The same way your studio wasn't like this in the past. The studio was just say 1, 2, 3, now, and then you start.
And it's still evolving.
But now it's evolving. So same thing in the medical world. A lot has changed, and diabetes now is better managed. So, but we'll go to the management. Let's start with
Sorry,
the
doctor, which of the type 1, type 2?
none,
Which
both of
one is
them.
preventable?
Oh no, well, type 2 can be prevented, even type 1 can be prevented. But I will say something. The type 2 mainly is as a result of abnormality in the receptors, which can be congenital. You can be born with receptors of insulin that are abnormal. And so even from birth, you already have the type 2 type of diabetes.
I know of stars, all these foreign stars that are born with it.
Yeah, so you can be born with even diabetes, whether type 1 or type 2. But there are certain lifestyles that can predispose you to developing either type 1 or type 2. So let me start with the type 1. Remember that the type 1 we said it is due to deficiency of insulin. So anything that destroys the pancreas, it can be an autoimmune disease. It can come from chronic pancreatitis from people taking a lot of alcohol. Alcohol can cause, can get the pancreas inflamed. Pancreatitis means inflammation of the pancreas. So plenty of alcohol can get the pancreas inflamed. And when it gets the pancreas inflamed, it destroys those cells that are supposed to produce the insulin. Certain disease conditions, some viral infections, Coxsackie virus, from sexually transmitted infection, HIV, can target the pancreas and destroy those beta cells that are responsible for producing insulin. So those are conditions that can predispose to developing the type 1 diabetes. For type 2, obesity has been found to alter the architecture, the anatomy of the receptors of the insulin. And that's why even the pregnant women, had also had increased risk of developing, mainly type 2 diabetes. So these are some of the lifestyles that can, that are risk factors that can predispose you to developing type 1 or type 2 diabetes, as the case might be. But as I said earlier on, some are born, they are called congenital forms. You're either born without the pancreas being formed. Some people can be born with the pancreas formed, but the beta cells are not formed, and so you can't have insulin. So they'll develop type 1. Some are born with abnormally developed receptors for insulin, and so they have the type 2 diabetes. So those ones are called the congenital forms of diabetes mellitus. I don't know if you get what I just explained.
Yes, you do. Now you're talking about the havocs.
Okay, so the havocs, because as I said earlier on, you have glucose within the bloodstream and no organ is spared. So that means almost all the organs, are inflicted or affected by diabetes mellitus. Okay, so we'll start from, I usually like to start from head down. So from the brain.
Okay.
You could have hyperglycemia that affects the eye, and you now have what they call diabetic retinopathy. Retinopathy means the small blood vessels that supply the small nerves, the optic nerve, the retina, they can be affected by high level of glucose. Because what happens is that when you have glucose in the bloodstream for too long, naturally those glucose ought to be mopped up into cells, and then they are supposed to be used to generate energy, what we call ATP. But when you don't have this glucose going into the cell, they are converted into a harmful substance called glycogen.
Okay.
So those glycogen will now accumulate on the walls of the arteries. So an artery that was probably 10 mm, you now have glycogen accumulating on the wall. What happens to the diameter of the artery? It becomes reduced. So the amount of blood that was supposed to reach, assuming you were having 100 ml of blood reaching that organ, now that you now have glycogen mopping, accumulating on the walls of the artery, the amount of blood will drastically reduce. And the body depends on glucose and oxygen for supply. So when the amount of blood that is carrying oxygen is reduced, going to the retina, they now develop what they call diabetic retinopathy that can lead to blindness.
Blindness, yes. We've seen cases like that. But blindness, blindness induced the diabetes. I was thinking to myself, I don't know, it's more in the Western world than here in Nigeria.
No, we have it. If
One of the actors, I think he's late now.
Eh?
One Nigerian actor has
Okay, diabetes mellitus.
Okay.
Okay. So diabetic retinopathy,
Mm.
yes, can lead to blindness. There are other things again diabetes can do in the eye.
Mm.
It can cause cataract.
Okay.
Can cause
So
cataract.
many of these cases that we see of people having cataract. most
Some,
of them-
not all,
Not-
some. So, but usually one of the things the ophthalmologist will do is to assess the random blood sugar, fasting blood sugar of those individuals.
Okay. Well, doctor, we are going on a break. When we come back, we're looking at the havoc diabetes causes and the management of it. Don't go away, viewers. We are coming back.
For sponsorship and advert placements, please contact 080-3688-6158. Last Word Leadership Podcast Studio. You have the last word.
Welcome back, viewers. Before we went on break, our expert was talking about diabetes havoc in the body and how it can be managed. Yeah, welcome back. Also, before we went on break, we talking about diabetes havoc and how we can manage these conditions in our bodies.
Okay. So we started with the brain, the central nervous system, and we talked about diabetic retinopathy that can cause blindness. And I gave you the pathophysiology of how it happens. It can also cause cataract. Then let's go down to the cardiovascular system. Remember I mentioned that accumulation of the glucose, with large amount of glucose, they are converted to glycogen, and so those glycogen will now accumulate on the walls of the arteries. When they accumulate on the walls of the arteries, they make the wall of the arteries stiff, beyond the fact that they reduce the lumen, the diameter. Remember I said if you had a 10 mm diameter of an artery and you have glycogen accumulated, it has reduced the diameter. Beyond just that is that they make the arteries that normally would have been pliable, they now make it thickened. Okay, so when they make it thickened, what we call arteriosclerosis, they make the blood vessels atherosclerotic. It predisposes the heart. So you now require a heart to raise its pressure higher in order to be able to pump blood to various structures. I don't know if you get my explanation. So you have the heart here. There are arteries that are coming out from the heart. These arteries are supposed to pump blood to various organs.
Yes.
Now those arteries have reduced in diameter. So it means that the pressure the heart needs to push blood through those arteries has to increase because the pipes have become smaller. Do you understand? So that is where we have high blood pressure coming from. So patients who are diabetic can have hypertension, high blood pressure, because the heart now requires higher amount of pressure to be able to pump blood through those small vessels. Initially, the vessels were about 10 mm, but now the vessels have reduced in terms of capacity. So that is one. The other hand again is that the heart needs to also pump itself, needs to get blood. The heart also is also an organ, so it needs blood to pump itself. Those small vessels also that supply the heart are not, in diabetic patients, will not be able to get enough blood to the heart, and so certain parts of the heart will now start undergoing ischemia, what we call myocardial ischemia. So that is the two things we've mentioned. We've mentioned that they can become hypertensive, they can have myocardial infarction. So let's now go to other parts of the body. The genitourinary system. The same small blood vessels, bigger blood vessels that were supplying the erectile tissues. Erectile tissues are tissues that helps you, within for men, that helps, the penis to become turgid and all that. Those blood vessels also can be affected, and they will now develop erectile dysfunction. So some men who cannot perform very well, who cannot last long, you must also look at, could this individual be suffering from diabetes? Because those blood vessels also that supply the penis, that supply the erectile tissues that help the penis to become strong and perform well, are affected. Do you understand? So that is on one angle. Then let's now go to some molecular thing that can occur. The risk of infections are higher in diabetics. Why? Because glucose is a good media for organisms to grow. So anywhere you have glucose, hyperglycemia, infections can grow and grow and grow and grow. So there are risks of developing all forms of infections, from cellulitis, infection of the skin, to urinary tract infections, to all forms of infections, because glucose, hyperglycemia, is a good media for organisms to occur. Beyond just that, hyperglycemia on its own affects cells that are called the soldiers of the body, white blood cells, lymphocytes. What those cells do is that they fight infections, they fight organisms. But when you have high glucose, it reduces the capacity of those cells to fight infections. So those are some of the reasons why diabetics, have higher risk of infections, all forms of infections, as compared to someone that's not diabetic. Then let us go to the foot. Because this, I also forgot to mention, there's what they call diabetic neuropathy. Those small nerves are also supplied by blood vessels. So those blood vessels, when they're affected, they also affect the nerves. So at some point, you can walk on fire and you wouldn't know, because the nerves are gone. Diabetic neuropathy. So they can develop what they call diabetic foot. You find ulcers on their legs, and then from diabetic foot, they can develop ulcers, large ulcers that might even require amputation. So those are some of the other problems that diabetes patients might have when it is uncontrolled. So how do we manage? In medicine, management usually will start with history.
Sorry, not let me take it back a little. You didn't mention the kidney.
Okay, beautiful. So yes, they can also have diabetic nephropathy. The same blood vessels that supply the kidneys, afferent arterioles, efferent arterioles, those blood vessels, they reduce in diameter. Do you understand? They reduce in diameter, and it can affect the excretion of urine. So usually, you are not supposed to find glucose and protein in urine. What I mean is that the body absorbs, the kidneys reabsorb glucose back to the system. It prevents protein from going into the urine. But in patients who have diabetes, because of the high level of glucose within the bloodstream, it forces the nephrons and then the glucose to find them. So sometimes you see individuals in the past, when they need to find ants going around, to mop around the area. It's because of the high load of glucose that has found its way into urine. You're not supposed to have a glucose going into urine. They're supposed to be reabsorbed. But because they are very high in the bloodstream, it pushes its way across the glomerulus, and then they find themselves, into urine. So they can have renal problems, from acute renal kidney disease to chronic kidney disease. Some of them even at the point they might even require renal transplant. So those are some of the things, some of the challenges. It affects virtually almost all the system. I mentioned diabetic foot. They can also have numbness in their palms, what they call gloves and stocking. Gloves is a glove we wear. So you touch them on their hand, they can put their hand inside fire, they don't even know, from diabetic neuropathy. So gloves and stocking, neuropathy. They can have glaucoma, they can have cataract, they can have myocardial ischemia, they can have hypertension. So it's a myriad of problems that diabetics have. How do you manage because of time?
Yes.
Management in medicine usually will start with history, examination, and then investigation, and then treatment. So your management will depend on how the patient presents. If the patient comes unconscious, some of them they become unconscious, what they call diabetic ketoacidosis or hyperosmolar hyperketotic state, hyperglycemic state. The blood sugar level can be so high that they become unconscious. So if they come as an unconscious patient, your management will be different. What you just do there is you want to sustain the patient, you want the patient to be alive, resuscitate, take care of airway, and bring down the glucose level as fast as possible. After you're taking your history, you want to find out what type of diabetes you're dealing with. You want to examine this patient. You want to be sure if the patient has other comorbidities. I said, yeah, it can affect the hand, it can affect the legs. You want to assess, and then you now go to investigations. Investigations, random blood sugar, fasting blood sugar, glycated hemoglobin. Glycated hemoglobin also helps you to know if this patient has been taking his drugs in the last 2 to 3 months. So it gives you an idea. It's not usually it should not be more than 6.9%. Then what drugs do this patient take? Ranges from insulin to oral hypoglycemic. There are various forms of drugs that we give to this patient, and the aim of those drugs is to either to provide the insulin that the body does not have, or to reduce the amount of glucose within the blood. So those are the drugs that we can use. And then there are other complications that we can manage. If the patient has diabetic foot, you want to dress the wound or you want to amputate, depending on the grade. If the patient has diabetic retinopathy, you send them to the ophthalmologist, let them see. I must mention this. The care of diabetic patient is multidisciplinary. What does that mean? You require the services of an endocrinologist. You require the services of an orthopedic surgeon if the patient has a diabetic foot. You might require the services of a cardiologist if the patient has, a heart problem. You might require the service of an ophthalmologist if the patient has blindness from retinopathy. So it's multidisciplinary. You also need the nurses, you need the pharmacist, you need all other paraphernalias of healthcare workers. So it's not just a doctor-centered thing. You also need other experts to work with you.
Okay. I think Doctor, what would be your advice to Nigerians? A lot of people don't even know about these things. People just think I'm eating good, I'm eating well because I have money, I need to enjoy myself. They don't know some of these things you take may end up cause problem for your body. So what would Nigeria, what would you want Nigeria to know about?
Fantastic. I'm happy you brought this issue. Lifestyle modification is usually the first thing we tell our patients. Cut down on refined sugars, exercise at least 30 minutes every day. Eat a balanced diet, avoid alcohol, avoid cigarette smoking, avoid lifestyles that will predispose you to them. So I forgot to mention, lifestyle modification is very key. I will discuss briefly on the diet. It's what we call diabetic diets. So we want you to have a balanced diet of 50% carbohydrate, 25% protein, 25% fat. So assuming you have a plate of food in front of you, breakfast, let's take an instant rice. So you have half of the plate should be rice. The second half, you divide them into two. The other half, vegetable and a piece of fish or a piece of meat. In the afternoon, you won't use eba. The eba should be about the size of your fist, not more than the size of your fist. And then you still divide the plate again into two. The other half, you divide them into two. Vegetable, and then a piece of fish, a piece of meat. And then in the evening, do fruits. And beyond 7, just water with your drugs. And then you'll be fine. So those are some of the modifications we advocate for diabetic patients. But so that you do not, we do not forget one thing. In as much as we want to make the blood sugar to be normal, we don't also want the blood sugar to be too low. Extreme low blood sugar kills faster than extreme high blood sugar. So you must also manage, signs of low blood sugar, tremors, and all that. So you must also have some cubes of sugar by your bedside, even when you're taking your blood sugar, you're taking your diabetic drugs, because it can go very low. And if it goes very low, we'll advise you put some cubes of sugar and drink it, and blood sugar will come down.
Thank you very much, Doctor. The time, what to say.
Oh, yes,
Long
because
best
we've been
time.
having a sweet time, and it's been quite educative and enlightening. Maybe we'll have to have a doctor back in the studio to tell us more on this lifestyle modification.
Okay. It's my pleasure.
Doctor, it's been a pleasure having you in the program. We look forward to seeing more of you.
Thank you.
Well, thank you, viewers, for listening to our program today. We enjoyed the program, and we hope you also enjoyed the program with us. Like Winifred has said, Doctor will be joining us later another day for the program to speak more on this lifestyle modification. For those of us who may not have diabetes now, we need to know how we can live our life better so we avoid having this problem in the future. Doctor, we thank you once again for joining us for the program. We also thank you for watching our program. This will be ending the program today. We'd like you to join us next time. Bye for now.
Thank you for watching. For sponsorship and advert placements, please contact 080-3688-6158. Last Word Leadership Podcast Studio. You have the last word.